Welcome everyone to this month's webinar, Going Concerns, Constipation and Urinary Incontinence. My name is Donna Greening and I'm a Programs and Services Coordinator at Parkinson Canada. Before we begin, there are a few items I want to go over. From coast to coast, we acknowledge the ancestral and unceded territories of Inuit, Métis, and First Nations peoples. To access closed captioning, click on the CC Live Transcript button and then click on Show Subtitle. If you'd like to submit a question for our presenters, be sure to write it in the Q&A window. The chat window is there for you to say hello and talk amongst yourselves. Rest assured that we will be monitoring the Q&A window. Before we start, we're going to share a video message from our President and CEO, Dr. Karen Lee.
Over 100,000 Canadians live with Parkinson's. We have one of the highest rates in the world. My name is Karen Lee. I'm the CEO of Parkinson Canada. My late grandfather lived with Parkinson's disease, and I know very well the importance of family and how they have to come together to support one another, but most importantly, the person living with Parkinson's. That is why I am dedicated and committed to ensuring Parkinson Canada continues to empower those living with Parkinson's. Each year, our programs and services reach over 10,000 people. We are a community. We are here not only for the person living with Parkinson's, but their family, friends, and their care network to ensure we all continue to thrive. Our advocacy efforts are focused on raising the voices of people affected by Parkinson's. Our Parkinson Advisory Council is made up of people affected by Parkinson's from across the country. They bring a diverse background and experience, but most importantly, they provide me and the organization with advice on topics that are important to them and their community. As a scientist, I know the importance of investing in bold and novel ideas that lead to breakthrough discoveries. At the same time, bringing researchers, clinicians, and people living with Parkinson's to collaborate to push the needle in our understanding of Parkinson's disease. We invest in the next generation of researchers and clinicians to ensure that we continuously understand the Parkinson's disease and also the care management of people affected by Parkinson's. When I'm in the community, I want people to know that Parkinson Canada is with them in every step of their journey with Parkinson's disease. People often ask, when is the right time to connect with Parkinson Canada? Is it when they have their first diagnosis? Is it when their symptoms get worse? Or is it when they need more information and resources? The answer is now. Researchers and clinicians are working tirelessly to find a cure. Meanwhile, every single day, 25 more Canadians are diagnosed with Parkinson's. Our goal is to empower people affected by Parkinson's to live well now.
Now let's get started. Winnipegger Ron Habesma was born in the Netherlands and immigrated to Canada in 1953 with his family. He and Anne, his wife of 50 years, have 2 children and 6 grandchildren. Having worked at various credit unions and then with the federal government for 29 years, Ron retired in 2009. That same year, after his physiotherapist noticed a tremor in his right hand, he was diagnosed with Parkinson's disease. Ron has lived with the effects of Parkinson's, including experiencing depression and anxiety, and most recently has experienced additional non-motor symptoms, including urinary incontinence and constipation. He is here today to share his journey with us. Welcome, Ron.
Hey, hello and good afternoon, everyone. We are here today to talk about 2 pretty embarrassing non-motor symptoms of Parkinson's disease: urinary incontinence and constipation. But before I talk about my experiences with these, I would like to share a little bit about my journey with you. I live in Winnipeg, Manitoba, and I was diagnosed with Parkinson's disease back in 2009 at the age of 64. My last year of working was not very pleasant, as I was off on sick leave many times with severe anxiety and depression and not knowing what the cause was. Since I was experiencing some back pain at that time, I was also seeing a physiotherapist who noticed that I had a tremor in my right hand. She sent a note to my family doctor, who then sent me to a neurologist who diagnosed me with Parkinson's disease. I went home, told my wife, Anne, and together we looked up a little bit more via the internet. It was quite a shock, as I'm sure we're all as patients went through when first diagnosed. I was sent to see Dr. Andrew Boris, one of several neurologists here at the Movement and Disorder Clinic in Winnipeg, where I still go every 6 months. The clinic deals mostly with Parkinson's patients and has several neurologists, a nurse, a social worker, a speech and language pathologist, and an occupational and physical therapist. And these are all dedicated to Parkinson's disease. What a blessing this clinic has been. I'm currently taking 12 levodopa carbidopa pills per day, 3 pills 4 times per day. Fortunately, not experiencing many side effects to these little yellow pills. I have right motor symptoms, and most of us are familiar with these. I have a slight hand and arm tremor. I slow walking with one arm still dangling by my side. Stooped. I say that I'm always looking for pennies, but I guess now it's coins. And lately, I've been experiencing some drooling. I've kept active with regular gym work, including weights and cardio work, walking and swimming. Exercise is very important for all Parkinson's patients. My wife and I decided to move into a condo because we're not sure what the future might hold. This move has resulted in less stress and a slowing of the disease. I still do a lot of gardening here at the condo in the summertime, and which has always been my hobby. My own journey with Parkinson's now has more non-motor symptoms. I still experience some anxiety, depression, night sweats, vivid dreams, restless leg, mild behavior, cognitive behavior, and lately urinary incontinence and constipation. I think that these symptoms are all normal parts of Parkinson's disease. I do believe, though, that a healthy diet and regular exercise play an important part in Parkinson's. I've tried to keep up to date with the disease, reading such books as the one co-authored by today's keynote speaker, as well as the Davis Phinney Foundation book, Every Victory Counts, the Canadian edition. As we say, education equals power. In this process, let us never forget our loved ones, our caregivers, our families who are living the Parkinson's journey along with us. Urinary incontinence is a very personal topic. Many do not feel comfortable talking about it, and I can understand that. However, in order to support each other, I think we have to be able to discuss it. I did express my experiences within a recent Parkinson's support group meeting. We have a very active support group here in Winnipeg called the Movers and Shakers. Pretty appropriate, don't you think? And we meet 6 times a year. The first signs that I had with urinary incontinence was that I did not feel empty after urinating. Then came the frequent trips to the bathroom. Before going out anywhere, made sure the bathroom trips was made first. When shopping, made sure I knew where the bathrooms were just in case. Thank goodness, Tim Hortons, where the bathrooms were always open and near the doors. During COVID, this problem was even more difficult, with many public washrooms being closed. When going for walks, I initially stayed closer to home just in case. And then on occasion, I was still too late, resulting in a peeing accident. When I did go for longer walks, I would at times have to pee outside as discreetly as possible, or would come home having dripped in my pants. You know, as an adult, this is very embarrassing. This must be even more difficult and demeaning for the ladies with Parkinson's, since there is no way to discreetly do these things outdoors. I do on occasion wear padded underwear. My doctor suggested I deal with my family doctor, or that's my neurologist suggested that, who sent me to see the urologist. And then he did an examination, the urologist, and sent me for a renal ultrasound or renal ultrasound. I'm not sure how to pronounce that. This test involves drinking 16 ounces or 500 mils of water 1 hour prior to the scan. I cannot empty my bladder until after the scan is completed. In my case, I had to wait close to 2 hours with a full bladder. The scan is done with a full bladder, which is very uncomfortable as they have to push down on the full bladder to determine the amount of urine that's in the bladder. After that, you're allowed to go to the bathroom to pee, and the scan is then done over again. In my case, they estimated that I still had a full cup of urine left in my bladder, even though I had no feelings that I had to go. For comparison purposes, 1 cup equals about 250 mils, where the average retention is 25 to 35 mils. This is not only damaging to the bladder, but could also be to the kidneys. I was put on medication to open things up, which has helped. I am currently on Mirabegron, which is to manage an overactive bladder. I take 1 tablet a day of 50 mgs. I'm also on tamsulosin, 0.4 mgs, 2 tablets a day. This is commonly known as Flomax. These 2 medications have helped me manage my urinary incontinence, even though I still do have some accidents once in a while. I have some trouble with constipation as well. There were times that I would not have a bowel movement for up to 2 full days. Of course, then it would get really hard, which was not easy. The sitting on the toilet and pushing then led to having trouble with hemorrhoids, which is not pleasant either. I initially tried to remedy this on my own with items such as Metamucil and adding extra fiber to my diet. This did help some, but not as well as I had liked. My doctor then sent me for a colonoscopy, which indicated nothing unusual. I have tried different methods and medication, and I'm currently taking Senoside, 8.6 mgs. I take 2 tablets per day. This medication is known as a stimulant laxative, which works by keeping water in the intestines, and this in turn causes the movement of the intestines. When I get really bunged up, I eat 4 to 5 prunes per day, which usually works. I do hope that by me sharing my own personal experiences, it has helped you realize that talking about these subjects does not have to be embarrassing. I sincerely suggest that if you are experiencing these real symptoms in your own Parkinson's journey, or other symptoms, that you go and discuss them with your doctor. Remember that education equals power. In conclusion, I look forward to Dr. Posthuma's presentation on these subjects. Thank you for listening to my journey.
Thank you so much, Ron, for sharing your story. It was very brave of you to share about such challenges that are sometimes hard to talk about. We're now going to hear from Dr. Ronald Posthuma. Dr. Posthuma is Professor of Neurology at McGill University and co-author of the book Parkinson's Disease, An Introductory Guide. He graduated with his medical degree from the University of Manitoba, completed a neurology fellowship at McGill University, a movement disorders research fellowship at the University of Toronto, and a master's of epidemiology at McGill. He's a clinical neurologist and movement disorder specialist with a research interest mainly centered around non-motor aspects of Parkinson's disease. His main areas of interest include early detection of Parkinson's, diagnosis and treatment of sleep disorders, including REM sleep behavior disorder, diagnosis and diagnostic criteria for Parkinson's, and clinical trials in the early stages of Parkinson's. Welcome, Dr. Postuma.
Well, thank you, and welcome to everyone. I see there's a lot of people here. It's a pleasure to be here. I'm just going to load up my screen here. It takes me half a second. So yes, I'm here to talk about the bowel and the bladder in Parkinson's disease. I'm a movement disorders clinician. I see Parkinson's patients all the time. What we're going to do is I'm going to basically do three things. And the first is to give you an idea of what's going on in your brain and your body that gives you these problems, and is talking about the autonomic nervous system in Parkinson's disease. And then we'll talk about the bladder, some tips and tricks that we've picked up over the years, and constipation, some tips and tricks we've picked up over the years. So a mixture of understanding and practical tips. So what's going on in Parkinson's disease? So if we were giving a talk on Parkinson's disease in the 1970s, we would probably show a picture that looks something like this. Okay, so this is Parkinson's. This is this black area. It's called the substantia nigra. This makes dopamine. If you don't have it, like this patient here, you get Parkinson's because you don't have enough dopamine in your body. And that's sort of what Parkinson's was for most of its existence. We knew right away that Parkinson's was associated with something called a Lewy body. And there are these little pale things that you can just see. You only see one of them. They're kind of hard to find, actually. And this is what you see under a microscope of a person with Parkinson's disease. And then in the 1990s, a gene was discovered, in a protein called synuclein. And then we realized that these Lewy bodies were full of this synuclein. And all of a sudden, if we would use these stains for the synuclein, whereas we used to have to hunt for these little pale blue things in the sea of pink, or pale pink things in the sea of pink, we can now see the synuclein everywhere. And this allowed us to start really looking much more carefully at what Parkinson's disease was. And it led to this really revolutionary concept, it's about 20 years old now, of Parkinson's staging systems. And so the idea here, this was done on people who just died of whatever cause, it doesn't matter. This is Heiko Brack, a German neuropathologist, and he went looking for synuclein. And he traced backwards, where do I see it the most? Where do I see it the second most? And made a staging system that came from this. And he proposed, in fact, that Parkinson's starts not in the areas of the motor system at all, but in fact starts in the areas connected to the brain, to the sense of smell, and what's really important to a nucleus called the vagus nerve, which we'll come back to, because that's the thing that controls autonomic function. And then it does this march up your brainstem, hitting the areas that are involved a little bit in sleep and in mood, and then finally gets the substantia nigra part, what I showed you earlier. And because your substantia nigra is pretty good at dealing with mild abnormalities, you're not showing up in a doctor's office until you're stage 4, 5, and 6, at which point the synuclein is in a lot more areas of the brain, even than we just saw. And we realize now later on, this wasn't realized at the time, that it's not just the brain that we see the synuclein. So if, for example, we can see it on biopsies. So if we do a biopsy of the skin or the gastrointestinal tract, you can see that the synuclein is there too. In the gastrointestinal tract, so that's everything from your mouth down to your colon, we see it most high up. So up here in the salivary glands, you can see that picture that I can't see, but maybe you can, with a guy having the biopsy. And then you can now see it all the way down into the colon as well. And very recently, it's been discovered that you can see the synuclein in the neurons in the skin. And it's a single punch biopsy that you can do to pick up the synuclein. And it looks like this is happening really early in the stages of disease, at stage 1 and stage 2. So the synuclein is in the nerves that are in your body, and not just in the nerves that are in your brain. And recognizing that the synuclein is in your body, but also everywhere in your brain has led to the acknowledgement that there are many, many symptoms of Parkinson's disease, many that involve other than just the motor tract. And what we see here, what we're talking about here is a group of conditions called autonomic symptoms. And this is the constipation, erectile dysfunction, urinary problems, blood pressure regulation problems, and temperature. Globally speaking, we're pretty good at taking care of the dopamine system. These tend to be the issues that most people run into with Parkinson's disease that we're not as good at treating. So what is this autonomic system? The autonomic system is basically in the lower areas of your brain, in your spinal cord, and in the areas of the body where I showed you that we can do those biopsies. And the autonomic system is two systems that work against each other a little bit, called the sympathetic and the parasympathetic. And they're always trying to get the right balance of, should I be peeing? Should I not be peeing? Is it time for a bowel movement? Is it time not for a bowel movement? Should my heart be going faster? Should my heart be going slower? And it really controls a whole lot. So going from the top, it controls the eyes, tearing, and pupils. It controls the heart and the blood vessels, the heart rate, and it controls the blood pressure, both in the heart and down in the veins in your leg. In the skin, it controls the sweating, which is very important in temperature regulation. It controls the sexual functions. And what we're talking about here is the bowel and the bladder. And so all of these systems are in fact potentially affected by Parkinson's disease. And that's the reason that you get the symptoms that you're getting. In other words, it's not something else most of the time. It is your Parkinson's. Okay, so that's what's going on. What are we dealing with the bladder? Okay, so in the bladder, the most common problem is exactly what was just described here. As by far the most common problem related to Parkinson's disease is urge, having to go too often, having to go too frequently. And essentially is the feeling that the bladder is overactive. And there are two main reasons that we get this, okay? The first is what I just showed you above, this sort of autonomic damage that happens. But actually, in the case of bladder specifically, the dopamine system is involved. So the original area of Parkinson's disease. And the dopamine system actually is responsible for decreasing the urge to urinate. And so dopamine, or when you don't have dopamine, you have to pee very often. And those of you who have experienced the fluctuations where the medications wear off and then stop working have probably noticed that when the medications are wearing off, you have to go pee more often. And this is off-period urge, and we see it all the time. So how will you experience this? The big obvious things are urge and frequency. So urge is that you have to, when you have to go, you have to go. You have to run to the bathroom. You can't sort of sit and think about it for an hour like you used to be able to. And frequency, obviously, just going too often. It also will show up at nighttime, and there's some special things that we'll come back to about nighttime frequency. And of course, if it's bad enough, you might become incontinent, or if it's not even that bad, but you can't move very well, you can be incontinent simply just as an artifact of the inability to move. So this is the symptoms that we're dealing with, exactly what Ron outlined before you. I do want to mention one important caution only for the men in the group here, is that the urinary frequency, having to go to the bathroom very often, and urgency as well, is also a symptom of prostate disease. And very often I've seen people with a mistake diagnosis of prostate. So I have my Parkinson patient in front of me and they say, well, I went to the urologist. He said my prostate was big, so I had an operation in order to fix that. But I had the operation and my bladder is every bit as bad as it ever was. And so if the problem is not the prostate, the problem is the Parkinson's, the last thing you want to do is try to fix something that isn't broken or is maybe a little bit abnormal, but isn't really the cause of your problem. But of course, many men, many older men will have prostate problems too. So how can you tell the difference? Well, there's a bit of a rule of thumb. It's the stream. So if you have to run to the bathroom or you're going very frequently, but when you start peeing, it's coming out pretty smooth and pretty easily and not dribbling and it's not getting stuck, that basically guarantees that it's not a prostate problem. Okay, so don't have your operation. If you're also having trouble peeing, it could be prostate, it could be Parkinson plus prostate, but you certainly can consider having an evaluation for your prostate. Okay, things that everyone can do, men and women now. So there are a few things that you can do that don't involve medications, okay? And these are relatively common sense. So if you're having urgent frequency, obviously everyone knows you would schedule the bathroom, you go pee before you get in the car. I think that's not rocket science. The other thing that may be less intuitive is if you are the sort of person who has off periods, correcting those off periods would potentially correct your bladder, so changing your dopamine medications around, but also just being aware that, oh, I'm due for my medications in about half an hour, and that's the time I'm going to get in the car. So maybe I should just take my pills a bit early or wait half an hour, and so that I'm on, so I won't have to pee when I'm on that hour-long drive. There have been some studies of bladder training, which generally involve physiotherapists. These are not available broadly at all. We have no access to it. But basically, the bladder training would involve some of the practical measures that I talked about here, plus some pelvic floor exercises. There was one study that showed some benefit. It's not dramatic stuff. So I think in general, if the symptoms are very mild, this may be sufficient, okay? I would say that most people who are getting real problems with this will end up needing to be on medications. So what are the medications that we use? In fact, those are two medications that Ron mentioned are the two that are on that list. So generally speaking, the classification is anticholinergic medications. That's what they're called. And there's a whole list of these. So oxybutynin, tolterodine, sulfethacin. They always have difficult to pronounce names on purpose because the brand names are easier to pronounce, such as Ditropan and Vesicare, etc. There's a very long list of these, and we're not going to go through them in detail. This is something that you work out with your doctor. Now, they basically reduce the urge to pee. So if people are having trouble getting the pee out, then this is something that you're a little bit cautious about using. The difficulty, or one of the feature of the anticholinergic medications is that some of them, particularly some of the older ones, also get into the brain as well. Most of the newer ones barely get into the brain at all. And so that's not always a bad thing, because anticholinergics are in fact an old-fashioned medication for Parkinson's disease. And still once in a while, I will use anticholinergic medications for Parkinson's. So people with tremor might get a little bit better if they go on a bladder medication. But the bad side, which is for most people, is it really messes with your memory. So anyone sort of over 60, even 55, you really start running into trouble with memory and concentrations and possibly hallucinations with medications that get into the brain a lot. In practice, I must say it's not a problem, but it's a side effect to be aware of, because every once in a while we run into trouble. The other medication, mirabegron, also called Myrbetriq, is a totally different mechanism. It's called a beta-3 agonist, and it's a once-a-day pill, usually 25 or 50. It's the only one of its class, so you can summarize it easier. This doesn't do anything in the brain at all. Its only real side effect is it causes a small blood pressure increase, but many people who are having trouble with bladders are also having low blood pressures when they stand up. So it's not always a bad thing to bring up the blood pressure a little bit. In my experience, this is well tolerated. Neither of these medications are cures, as I think Ron had noticed. They take the edge off it. It's hard to get rid of bladder problems completely. There are some other bladder problems that people can run into. So nocturia basically just means having to pee in the middle of the night. Now, it's very normal to pee once or twice in the middle of the night, especially men after a certain age. But if it's getting to be too much, then what can one do about it? First of all, this is kind of an interesting fact, but if you are sleeping, if you're actually asleep, your bladder gets the reaction to make less urine to help keep you asleep. And so if the sleep is disrupted, then you have to pee. So many people are thinking, oh, it's because I have to pee that I can't sleep. But it's in fact, it's more like I can't sleep, therefore I have to pee. And so sometimes some of the measures that you can use to improve sleep, which is a whole nother talk, can sometimes help with nocturia. Another thing is that people who are dropping their blood pressure when they stand up, in Parkinson's, we don't really care what the blood pressure is sitting. I want to know what it is lying. I want to know what it is standing. If there's a big difference between those two numbers, sort of 20 or more, then when you lie down, your blood pressure is going up, and that gives a lot of pressure on your kidneys. All of a sudden, the blood pressure is effectively higher, and you pee. And so then you have to go to the bathroom during night. So sometimes fixing the blood pressure drop can actually fix the problem. The final thing that we'll sometimes use is a nasal spray. This is what the kids use for bedwetting. It just basically makes you make less urine at night, simple as that. You do have to require some monitoring. So we do watch a little bit for the sodium, and so it takes blood tests. So it's not my first choice. I'd rather do something that doesn't require you to go for blood tests every couple of months. The final other problem is retention. In other words, inability to get the urine out. This is almost always experienced predominantly by men. If it's experienced by women, we definitely need some subspecialist help because it's not common and could be indicators of other conditions. Generally, as a neurologist, if I'm dealing with retention, I pass the buck to our urologist colleagues who are bladder medications, because they have the expertise in prostate treatments, catheters, all these sorts of things that I'm not very familiar with. So that's everything about the bladder. Let's move on to constipation. The bladder can be tough to manage, but I must say constipation you can usually take care of if you know what you're doing. So here's an interesting fact. So I mentioned that constipation, maybe these autonomic factors start very, very early. And we do see that people, oh, sorry, there's a fire alarm where I am. I'm going to talk through, and if I see smoke, I'll leave. People with constipation have an increased risk of developing Parkinson's, about a 2.5-fold increased risk of developing Parkinson's disease. And what's really interesting is that when we watch people who here are people who develop Parkinson's, but when we look back in time, that constipation seems to go back a really long way. And so we directly have observed it 15 years before. And there are other studies in which people get constipation at the age of 30, and it predicts their Parkinson's risk at the age of 50 or 60. And so that could suggest a couple of things. One, it could be a very early disease sign. In other words, a very early marker of early prodromal Parkinson's disease. But it makes you wonder a little bit if it's maybe a risk factor, even if constipation could increase the risk of Parkinson's disease. And so some researchers are thinking a little bit about that possibility. Let's just talk about constipation in general. Who gets constipation? Most people with Parkinson's gets constipation. I'd say about 2/3, 3/4 of patients with Parkinson's disease are experiencing or have experienced constipation at some point. And so if you're looking for another explanation for your constipation, you almost don't need to bother, because it almost always is the Parkinson's that's the problem. So for example, that colonoscopy, I don't suggest colonoscopies when people with Parkinson's have constipation, because everybody has it. When you have to worry, well, first of all, the frequency. You'll ask yourself, how often do I really have to have a bowel movement? Well, I think there's no real fixed rule. So if people are having bowel movements every other day, that's fine. If you're fine, that's fine. Okay, people will find that if it's been a couple of days, it gets much more difficult. And so if it goes 3-4 days, then we can really start to run into problems. You can get stuck, you're in emergency rooms. So it's really an individual decision on when you really need to do something about it. The other difficulty, of course, is that if the stool is very hard, then it hurts. You can get hemorrhoids from the strain, et cetera, et cetera. So this could be another indication that we need to do something about it. A very common question that I get from Parkinson patients is, can I get addicted to my laxatives? Because there are people out there who become dependent on the laxatives. This is usually people who are using laxatives for purposes of weight loss, which is a really bad idea. And then eventually your system sort of regulates it as a problem, and it sort of takes corrective measures, and so it doesn't happen. One of the systems that does that is the fluid system, but the other system is the nervous system. And Parkinson's patients don't really have any nervous system that in their gut anymore. It's all being affected by the Parkinson's disease. So I've not really seen this to be a problem. So my general rule is, it's okay. Whatever it takes to make you work, let's have one less problem. The real dose limiting factor is if you get diarrhea, and then we need to do something about that. Okay, so now we decide we want to do something about our constipation. What can you do? Actually, this is one area where your own individual, you don't need a doctor for a lot of this stuff. And so there's a lot that you can do on your own. So there's 3 big lifestyle tips. First of all is keep your fluid intake enough. Okay, now this is not 10 liters per day, because you're also having bladder problems, right? Maybe that you don't want to have 2 problems at the same time. But I do find a lot of people with Parkinson's don't tend to drink a lot of fluids. So make sure you're getting at least 1.5 liters a day of some sort of liquid into your body. Keep an active lifestyle. So the more exercise is a very strong stimulant for the bowel and doesn't even require the nervous system so much. So people who will often find when they go for a run, when they go for something very vigorous, that does help go to the bathroom. The third is the diet. So in general, you want to use fruits and vegetables as much as possible. That's part of a healthy diet in general. And so you may just non-specifically just take more fruits and more vegetables, and that will help. Many people, of course, are aware that things like prunes and dates are almost laxatives in their own right, and you can use those as you wish. And then keep up your fiber intake as well. So not white bread, but whole grains. You can use bran, like the bran flakes that you get in the cereal, or just a bit of bran sprinkled on your food can also help. Our nurses have a recipe that they give to our patients. I've not tried this. Some of our patients really like this. It's very, very simple because it's just food. They take 2 cups of applesauce, they take 2 cups of all bran and a cup of prune juice, and they mix it, and you mix it together, and you can keep it in the refrigerator for a reasonable amount of time. And then every morning you just go out and have a couple of tablespoons, so big soup spoons, you can take a lot more than 2 tablespoons if it doesn't help, because really this is just food that we all could be eating, and it'll sit in the refrigerator for next month. If you want, you can add yogurt to that as well, and I'll show you why that's the case. So that's the sort of simple recipe. You can go back to the recording and if you like, and sort of get it. The next step would be to think about some of the things you can get over the counter by yourself. So this is one that's actually relatively new. These are the probiotics. So yogurts, Activia is one example where any yogurt really has probiotics in it. That's kind of what yogurt is. But you can also buy these capsules as well. And there have now been some studies that show that these really do help. So for example, one study, it wasn't this particular form of probiotic, found that 53% of people who would take the probiotic had at least some improvement in their constipation, but 11% of the people who took a placebo, in other words, just a sugar pill with no probiotics, had improvements. So that's pretty good, clear evidence that it does something. So it's relatively simple to do on your own. Bulking agents, so the common one that's used is Metamucil. I must say I've not had very good luck with Metamucil. It doesn't seem to make a very big difference, but some people can find it useful. You can add it to your diet. One of the commonest things that we use are the herbal remedies. And so this is Senna, or Senokot is the one that's used by far the most. It comes in a tea that you can just buy at the grocery store, for example, or it can come in pill form, which is basically just the herb crushed up into the form of a pill. And you take it once a day, once or twice per day. It's what's called an irritant laxative. It sort of makes the bowels a little bit irritable, and so makes them contract a little bit more. Theoretically, this is one of the class of medications that your body can get used to, but I've not had the experience that seems to be the case, I must say. So those are the simple things that you can do over the counter. Now, the other next steps, depending on where you are, some of these are over the counter and some of these you need a prescription. Many of these are over the counter, so I'll just tell you about all of them, and you really have lots of options. Probably the one that we use the most commonly are what's called the osmotic laxatives, which are essentially powders. And there are many: Laxidate, Pegalax, Emalax, Restoralax. There's a million of these, and they're generally bought over the counter. And they come in a powder form. Usually the Laxidate, for example, is 17 grams per day. And you just take it once. And being osmotic, what they do is they're sucking water into the colon, increasing the volume and the liquidity of your stool. And it's not something we think that you would get used to particularly. This is something that you could probably take every day as well. There are other stimulants, Dulcolax, Xlax. Some of these actually contain Senna inside them, Senokot, what I showed you earlier. And usually prescription products such as lactulose, which is you have to ask your doctor, really quite strong, can really make people go. If you get stuck, some of the suppositories, and you put a glycerin suppository up your rectum, obviously it doesn't help at the top, but if it's stuck down low in your colon, that can help as well. And some people, if it's really, really stuck, can use enemas, either rectally, or there are oral enemas as well. I'm not sure I would suggest those, but the rectal ones are certainly relatively safe and can be done. So that's what we'll talk about. So first of all, recognize that the bowel, just to summarize everything, the bowel and bladder problems are caused by Parkinson's directly. It's the dopaminergic system for the bladder, and then the autonomic system for bladder and the bowel. I find the bladder is a little bit tough to fix completely, but we can take the edge off. So some of the things like scheduling, knowing when your off periods exist, training, and then some of the medications, which really do require you to talk to your doctor to get these medications. Constipation, plenty of options. Remember to keep your fluids adequate. Remember to get some exercise, have a healthy diet with fruits and brands, etc. And then we have the herbal medications, the probiotics, then the powders, and then prescription medications as well. So those are all options. And with that, I'll stop and thank you for your attention. Happy to take questions.
Well, thank you so much, Dr. Postuma. That was some great information about how to manage both incontinence and constipation. I am going to share that recipe with everyone in our follow-up email. We're going to launch into some of the questions that have been submitted, so just give me half a sec. All right, so many attendees are asking about the other risks of long-term use or regular use of laxatives and enemas. I know that dehydration and electrolyte imbalance are possibilities, but can you speak more on those or any other potential risks?
So most of the risks really are related to chronic diarrhea. Okay, so for example, electrolyte imbalances and some of the regulations of the body. But if you're having chronic diarrhea, I've gone too far, and you'll cut back spontaneously. So I really don't think it's a very major issue. The thing that will stop you is if you're having diarrhea, especially if you have Parkinson's, it's hard to get to the bathroom on time. That can be a big, big problem, and that'll stop you enough. Other than that, if you're keeping the doses reasonable, and often I would suggest you use, if you're having trouble, to use a low dose of this, a low dose of that, and a low dose of the third thing, some fiber, some brands, so maybe a bit of Senecot and maybe some Lax a day. Maybe you don't need the whole thing. Maybe you just need, 1/3 of the usual dose. So these things in combination, I think it's okay. I don't think you need to worry about overuse as long as you're not having diarrhea.
Do you find that some people have that teeter-totter where they may have overused too much and then now they've got the diarrhea and then they start taking an anti-diarrhea and then they can't quite find that balance? Do you find
Yeah.
that? And if so, what do you suggest to get off the teeter-totter?
Yeah, never take an anti-diarrhea medication unless you're in real trouble. Like the Imodium and stuff, they will, if you have Parkinson's, that'll clog you up really, really profoundly. Any diarrhea that you're getting a side effect of a laxative is gone within a day, maybe 2 days, something like that. It's not hanging around in your body. You've just excreted that. If you had diarrhea, you just got rid of whatever that laxative is. So all you do if you're on the seesaw is just next time go back to a lower dose of the laxative.
Great, thank you. So this is a question for Ron Halbezma. So Ron, if you want to turn on your camera. You were asked, what have you found to be the most effective and comfortable disposable products for incontinence? There's so many on the market.
Thanks, Donna. You know what? When I started having troubles, I quite often experimented with pads initially, and those were not very successful. I didn't find them to help. But I do, what I'm using now is, they're called Attends, and they're an overnight underwear. So that's how they're advertised. And I use those when I go for long walks just to make sure, not all the time, but once in a while when I don't trust it. And I believe that they're available at Shoppers. I find those very comfortable and very easy to use. You can put them on, put your underwear over top of them if you want, even your own personal underwear. So it works really well.
Okay, great, thank you. And if you wanted to turn on your camera, because if there's more questions, then we can see
Okay.
you when you're answering. That would be great. Let's
We'll
see
try.
what the next one is. So someone said that they were told that acidic foods like oranges and tomato, oh, and this would be for Dr. Postuma, sorry. That they were told that acidic foods like oranges and tomatoes can make their incontinence worse because they might irritate the bladder. Now, I know that the National Association for Continence says that fruits like bananas, apples, grapes, coconut, watermelon, and vegetables like kale, lettuce, cucumbers, squash, potatoes, broccoli, carrots, and bell peppers can help people with overactive bladders. Is that also true for someone who has Parkinson's, Dr. Postuma?
Yeah, so we're not really sure. So yes, obviously, if you're having an irritated bladder wall, then by all means, those things might make things worse. In the case of Parkinson's, that's not really the problem, right? The problem is the nervous system controlling it. And so, yes, adding an additional irritated bladder wall on top of your already nervous system issue could be a two birds with one stone, but not necessarily. So I would suggest, if I was experiencing this, is that I just see, Try it on your own and you'll know, because you don't want to take a whole bunch of really healthy foods and just disappear them from your diet for something that doesn't really make any difference. So just have a practical approach to it. If you see that it makes it worse, be aware of it. If you see it makes it worse, then you might stop it. I will say the other thing that works on the nervous system level is caffeine. Caffeine is well known to be a diuretic, but it also does sort of stimulate the bladder a little bit. And every once in a while, I've run into patients who have incontinence only when they take caffeine. So be aware of that. Caffeine's fine, it's healthy, you can take it as much as you want, but if it's irritating your bladder, then stop it. But with all of these things, just see what happens in your own individual thing, because you don't want to take a rule, read it, and then change your whole life for something that doesn't really make a practical difference for you.
That's very sage advice. Thank you. There's another question for Ron Halbezma. Someone asked, how did sharing about your incontinence with your support group and your doctor impact you?
I guess it made me more confident. I didn't feel that it helped me realize that even though you have these issues, that it's a good idea to talk to others about them, to discuss them, and to feel free to discuss these things with anybody. And just because the topics themselves are kind of embarrassing, I think it's a freeing aspect of it by talking to others about it.
Yeah. Do you find that it gets easier the more often you're doing it?
Absolutely. Absolutely. The first time you stand up and you talk about urinary incontinence, you find that people kind of look at you and say, oh, well, wait a minute, I did have that problem too, but I didn't realize that you could do something about it, or they were embarrassed to talk about it. So I think this was kind of a freeing aspect for me.
Great. Well, thank you for sharing. Here's a question for Dr. Postuma. Are there specific exercises that can help with constipation?
So I don't think there's one particular magical exercise that really makes much. It's basically the intensity of the exercise that probably is what's important. I guess you could imagine if you're jumping around a lot, there might be a little bit of extra motion sort of stimulation. But no, it's just, we're talking mostly sort of cardiovascular kind of exercise, up and down the stairs, going for a run, going for a very brisk walk up a hill. That's the thing that stimulates the bladder probably more than anything else. Of course, if you're lifting weights, you're doing a Valsalva maneuver, so that might stimulate the bowels a little bit. But yeah, there's no one particular exercise. Just in general with exercise, you want to do some moderate exercise, but you want to make sure in general, for Parkinson's in general, that a bit of it is a bit more intense, makes you tired, makes you sweat. So not just leisurely walks for hours and hours, but a little bit where you're really challenging yourself. That may make that probably makes a better difference in Parkinson's disease than moderate exercise.
And do you think some exercises that perhaps work your core a bit might help more to get the bowels moving?
Maybe, yeah. Yeah, planks and yeah, you can imagine, simply because what you're doing there is if you're holding your legs up in the air and putting them up and down, you're increasing your pressure in your abdomen. So there might be sort of a just general effect of that. But I don't know the answer to that. I must say, I think it's the vigorous cardiovascular exercise that probably stimulates the bowels more than the muscle exercises.
Mm-hmm. Great. So this question is for Dr. Postuma, but Ron Halbezma, you might have something to add at the end. Actually several people mentioned that they are very concerned about incontinence when they're traveling and bathrooms are few and far between, or when they're not at home, like if they're out for a walk or shopping. And are there strategies to use to improve predictability and regularity?
Yeah,
Dr.
I assume we're talking about the bladder.
Yes.
So I think they're your own individual strategies. I don't think there's any sort of rule that you can come up with, right? I mean, so yeah, when you walk into the mall, whatever, know where the bathroom is. Don't be shy about asking to use the bathroom in a bar or restaurant that wouldn't normally let you, okay? And just say, I have Parkinson's, can I please use your bathroom? Something like this. That gets you a pass into a lot of things. But no, I think every individual circumstance is different. And so you just have to be your own strategic person. Ron, you might be better to speak about this.
Well, I agree with you, Ron, that it's exactly the very same thing. You have to make sure where your surroundings are and where you're at. And if you don't feel comfortable and you do want to go for a walk, well, stay close to home. Walk around the block. Don't go far. But the other strategy, of course, is just use some common sense, like Dr. Posthumus suggested, as well as pads or a diaper, not a diaper, but an adult attend, for example, that I use. Any of those kinds of things help. Any of the strategies.
I guess that it's really true. An ounce of prevention, it really is worth that pound of cure. So planning ahead, just in case you need it, it's like a little insurance policy when you're out and about.
Yes, that's correct.
Someone says that they were told that the bladder muscles get weakened by levodopa, so it ends up holding a lot without signals to empty. Is that correct?
It's not weakened. That's not, so it's basically sort of kind of what I said, but in reverse, right? So the dopamine in general sends the normal signal that you don't have to pee. Okay. And so when you're low on dopamine, then your bladder becomes more irritable, feels that it has to pee a little bit more. But of course, that's involved in a balance. So if you're already having urinary retention, of course, then it would be better if you weren't on your dopamine. But really, it's the levodopa is restoring your normal state of your bladder more than the other way around.
Okay, great. Thank you. Now, also, Dr. Postma, you mentioned in your presentation using probiotics like Activia or the capsules. Would that be the same for prebiotics like Restore Fiber gummies?
So I believe Restore Fiber would be fiber. So fiber, maybe I don't know what those are actually, but fiber is fiber, and so it doesn't really matter how you get it. I don't know what a prebiotic is. I actually never heard that term before. Maybe I think you're just referring to fiber.
Okay, all right. We'll just move on to the next one then.
Yeah.
Is the urinary urgency in males with Parkinson's more a result of Parkinson's or simply normal aging?
So yeah, I think, like I said, be aware of the prostate. Okay, that's the big thing. So is that normal aging? Well, it's very common aging in men. So be very, very aware of that. Most of the time, I will say it's the Parkinson's. That whole long list of things that I showed at the beginning of the slide. It's good to know that all these are potential features of Parkinson's disease, because I must say, when someone mentions any one of those symptoms, it's usually the Parkinson's that's the explanation for it. Every once in a while, it's something else.
Okay. All right, we've got some live questions here. What about using a footstool when sitting on the toilet to help get your body in the position closer to a squat? Have you heard of that? And what's your thoughts on that?
Yeah, it's a more physiologic position to have a bowel movement. That's where our bodies are used to. Mechanically, it certainly helps. It gives you basically a straight shot instead of having the stool having to go around a curve. So it does make a little bit of sense to do it that way.
Okay. I guess it's probably quite common that with men who have prostate complications and end up having surgeries, and that they found that has not helped. Is there any thoughts on what else they could do if the prostate's not helping and they're still having the problems?
I think it's exactly what I just said. It was never the prostate. It was always the Parkinson's, and that's almost always the case when that happens. So you have a prostate surgery. It doesn't go, but the prostate surgeries are pretty successful. It's pretty hard to miss. They basically just ream a hole right through, and there's plenty of space now. So unless it was an unsuccess, something went wrong with the operation, we could presume that the prostate has been taken care of by that operation. So it really means it was the Parkinson's.
Okay.
Maybe I'll just ask, I just realized that what a prebiotic, I think what it was referring to, we're referring to foods that tend to promote the normal or the what would be thought to be beneficial bacteria in the gut. Okay,
Right.
so things like honey and stuff like this. Okay, yeah. There's no evidence on those. They've not been studied in Parkinson's disease. There are all kinds of things that might complicate use of prebiotics in Parkinson's because the microbiome was very, very affected just by the constipation itself, and maybe by other issues about the Parkinson's disease. So I don't know if prebiotics would work, but probiotics definitely do. And so that's just as easy, right?
Great, great, thank you. So I know in your presentation, you mentioned that people have to pee upon waking, not that having to pee will wake them up. We've had someone who wears a CPAP machine for sleep apnea is finding that they're still being awakened 3 or 4 times a night by their bladder, and they think that that's interfering with their REM sleep. Is there anything that they can do to help that, or are there any side effects that could, be involved?
So the CPAP machine fixes only one problem, apnea. It doesn't do anything else at all to everything else that goes wrong in sleep in Parkinson's. And sleep in Parkinson's really is caused by a variety of factors. So having not enough dopamine, for example, you're stiff, you're sore, and you need dopamine to sleep. And then it's also just the areas that, like I showed you, the areas involved in controlling the sleep are affected directly in Parkinson's disease as well. And so it's certainly no surprise. And so even if the apnea is corrected, you still may be sleeping very inefficiently, waking up a lot during the middle of the night, all these sorts of things, and that certainly can make you have to pee. If you are generally people who sleep like a rock, don't find that they have to get up to pee in the middle of the night. So it really does, I think, require a little bit of light sleep in order to do it. I think that's the biggest factor. And it's not a problem if you get up and you pee and you go right back to, you fall right back asleep again. No problem. We don't have to fix this problem. That's not a problem, right? But it's when you can't sleep again that it's a problem. And that's really what we deal with in Parkinson's a lot. And so that's a whole nother talk. The sleep in Parkinson's is a huge topic.
Right. How about you, Ron? Do you have any strategies for trying to stay asleep at night, not have to get up and go to the bathroom?
No, I don't. I usually get up maybe once or twice during the course of the night, but I'm lucky that I can fall asleep again quite quickly.
Oh, great. Dr. Postuma, are surgical interventions for urinary urge incontinence a bad idea for Parkinson's patients?
So I think this would be particular to, especially to women, I think, and really those of us women who've had children, that does mess up the urethra a little bit. And so if that's a problem, if that's a second problem, and that's typically stress incontinence, it's usually things like you cough and a little bit of pee comes out, or you get up and sit down on a chair, a little bit of strain, a little bit of pee comes out. That's perfectly appropriate because it's a completely separate problem. Now, surgical interventions for urge incontinence. So we have Botox injections, but I think what you're talking about is mostly the sort of corrective bladder issues related to, especially being a woman who's had children, and those would be fine. Just don't assume that they're going to fix the problem because maybe that's not the problem, right? So it's a real problem. You actually do have a descent of your bladder, but the real problem is your Parkinson's. And so you're always much more reluctant to do any surgical operation unless your urologist is 100% aware that you have Parkinson's, and we're pretty sure that the problem is directly caused by the bladder abnormality or whatever abnormality that surgeon wants to correct.
Thank you. This is going to be our last question. Someone's asking about timing when taking Metamucil or other aids for constipation, as they understand that taking a dose of that could potentially interfere with the effectiveness of taking Parkinson's medications.
Not the laxatives themselves. It's you don't want to take your Parkinson's medications after you've had a meal. That's the thing. You want to take it before you eat. But there's no real direct. No, don't worry about it. You can make your life easy. If you want to take your Senecot at the same time as your levodopa, no problem. You can take it at the same time.
Great, thank you. Well, that's all the time we have today for questions. Thanks so much for such great questions, and a very special thank you to Dr. Ronald Postuma and to Ron Halbezma for such great information and a very candid discussion on a topic that some people might find embarrassing to talk about. Watch your email inboxes for a follow-up email that will include a link to the recording of this webinar and any resources or other links mentioned here today. We hope you'll join us for our next webinar, Simplifying Daily Life with Gizmos, Gadgets, and More, taking place on Wednesday, June 21st from 2 to 3 p.m. Eastern. Watch your email inboxes for more details and a registration link. On behalf of all of us at Parkinson Canada, I'd like to thank you for joining us, and I hope you enjoy the rest of your day. See you next month.